Okay, so for today's presentation, just to give you a bit of background information, NPS Medicine Wise has partnered with the National COVID-19 Clinical Evidence Taskforce. So they've written a national evidence-based guidelines for COVID, and these guidelines are a living document, so they are continuously updated as the evidence evolves as well. So for today's session, it's my pleasure to introduce Associate Professor Julian Elliott. He's the Executive Director of the Task Force. So today he'll be speaking to you about their work, and really it's a great opportunity to seek feedback from all of you with health services and from our frontline workers as well on the guidelines and any feedback or suggestions you may have as well. So I'll pass it over to Julian
now. Thanks, Anne-Marie, and thank you to you and the others at Choosing Wisely for inviting me to come and present at this webinar. I will share my screen. So can I just check that you can see my slides?
Yes, I can see them.
That's great. So I'll give you a bit of an overview of the task force, also some introduction just about the living evidence model, which is the approach that we're using in the task force. And I hope to have substantial time for discussion because I think all of you have experience that is going to be very relevant to us in thinking about the further advancement of what we're trying to achieve here. So first of all, my interests. So I'm Executive Director of the new task force, also chairing the Australian Living Evidence Consortium, which I'll mention later. I'm a practicing physician at the Alfred Hospital in infectious diseases. And then I have a number of roles with Cochrane, both globally and locally, with a particular focus on technology. And through that also co-founded and lead Covidence, which is a non-profit software platform for systematic review. So the context, of course, is evidence-based practice. This is the theory, the model will be familiar to all of you. So the concept, of course, that we use multi-stakeholder groups to define important clinical problems. And then from that develop a series of systematic reviews using the established methodology that feed into development of high quality grade-based guidelines, which are then used through a number of knowledge translation activities to improve clinical practice. Now, of course, there are many, many challenges to the implementation of this model, and all of you are really, I guess, embedded in that work in your health services. From the point of view of the evidence and guideline piece of this ecosystem, there was a very useful report developed by NHMRC now 5 years ago, which describes some of the key challenges for guidelines in Australia. And you can see there listed some of the key elements that NHMRC felt were really holding back guidelines and their ability to deliver improvements in our health. So inefficiency of the process, often very poor quality, lack of capacity in the sector generally in Australia, lack of investment in IT, inaccessibility of the outputs, and obsolescence. And so we characterize many of these challenges in this simple matrix to say that there's a lot known about the way that we develop high quality evidence and high quality guidelines such that we can trust the output. But achieving that level of quality is very, very difficult, time consuming, resource intensive, and it's then very difficult to keep up to date with the latest research. In contrast, we have, of course, many quick and dirty approaches, such as narrative reviews, opinion pieces, etc., which can often, of course, be quite up to date. But there's now 30 years of research really showing that those methods are very prone to bias. And so we have this trade-off with health evidence. We have a trade-off in health evidence between quality and currency. And a lot of our work is really about how do we break that trade-off and how do we ensure that we get health evidence that is that contains both of those qualities. So the model that we've developed is we call living evidence. And within that, we have living systematic reviews and living guidelines. Very briefly, what do we mean by living guidelines? essentially they are guidelines that are both trustworthy and up to date. And so what that means is we have this contrast with the existing model, which I'll just walk you through briefly here. So in the current model, we have what we call climbing the mountain. So all of the work that goes on to develop the initial set of guidelines, developing the scope, the systematic reviews, the guidelines, approving, disseminating. It's an enormous amount of work, and usually by the point that when that work has been completed, we say we have a guideline that is now up to date. It's then published, and usually, of course, the team will then disperse, and that guideline remains in our healthcare system. But of course, the world doesn't stop still. In fact, research continues. And so we then have an up-to-date guideline, but as research continues to flow, that guideline will progressively become more and more out of date, reducing its accuracy as a reflection of a current research base. And we would argue also then reducing its utility. Then at some point in the future, a decision is made at some ad hoc point to update the guideline, and then the mountain must be climbed again. And as many people will describe, it's often as much work as the original guideline to do the update. So in the living evidence model, important to note that that initial work remains unchanged. So the baseline guideline still needs to be developed, approved, disseminated. But what changes then is instead of the work stopping, we're moving to what we call a living mode. Very regular researchers of the relevant bibliographic databases, updating our systematic reviews frequently, and that being fed through to the guideline panels, where they will make a decision about whether recommendations should be changed or not. And then any of those changes are then disseminated to end users. So it's not no effort. There is, of course, effort required in maintaining the guideline in the up-to-date state. But the main difference is that that update is distributed more evenly over time. And so through that, we're able to maintain the rigor of the process, but also to ensure that this resource is up to date with the latest research. We are also aware that guidelines sit within quite a complex evidence ecosystem. And so this is just a schema to describe how some additional pieces fit together with living guidelines. So here at the top, we have newly published research, which goes through the usual systematic review process, again, developing systematic reviews and evidence summaries, but that are dynamic, they're kept constantly up to date. And so therefore, we are producing regularly updated recommendations. Through some of the technologies we use, they're able to be disseminated through mobile devices. And we're also exploring the integration into electronic medical records and also into decision aids for patients and clinicians. Then through a series of very complex activities, which I'm sure many of you are involved in knowledge translation, the aim, of course, is then to change clinical practice and policy. From that, of course, there are many mechanisms that are monitoring clinical practice. So things like registries, electronic medical records, administrative data, other large observational data sets. And so, of course, they also then become a source of information with all the caveats around the use of observational data, of course. And then also just to note that up-to-date evidence-based recommendations are also very useful in also characterizing where the evidence gaps are, and so therefore can be used to feed into research prioritization activities and help to shape new research, which then flows back into the process of systematic review and guideline development. So this is a concept that we first published on now about 6 years ago, and over that time we've been developing the model, the methods, and a number of early demonstration projects. Over the last few years we've had the development of living systematic reviews in the Cochrane context, so living Cochrane reviews, and also a number of non-Cochrane living systematic reviews. And through that work, we have developed some guidance documents which are available through the Cochrane website. If you just search for Cochrane Living Systematic Review, you'll find the document there that outlines our suggested methods for undertaking living systematic reviews. And then a couple of years ago, we formed this group, the Australian Living Evidence Consortium. So this is a group led by Cochrane Australia at Monash University, but containing peak groups within 5 chronic disease areas. So stroke, diabetes, heart disease, arthritis, and kidney disease. And through that group, we've been further developing methods and processes, including the use of some of the technologies that can make this work more efficient, and developing a number of living guideline demonstration projects. The first of those was the National Stroke Clinical Guidelines. So through some funding from MRFF, we were able to update those guidelines and then transition into living mode. And so those guidelines are now, for the last 6 months, have been kept constantly up to date in a living mode. And that's been extremely useful, as during that time there have been some real breakthroughs in stroke care. For example, in endovascular clot retrieval, in thrombolysis, which have been able to be incorporated into those guidelines within a few weeks. So this really is the first truly national evidence-based living guidelines, and so a great demonstration of the feasibility of this approach. And then more recently, we've been working with groups in diabetes to develop living national guidelines for the use of new technologies in type 1 diabetes, and the use of therapeutics, so glucose lowering therapy in diabetes. So all of that work has been the foundation upon which we've now launched the National COVID-19 Clinical Evidence Taskforce. This is a group of peak clinical bodies that has come together to speak with one voice. We started in mid-March when it became obvious to many of us, and in discussions with other clinicians, that there was a lot of redundant effort, a lot of people developing their own statements, policies, guidance, also a lot of health service specific or hospital protocols. And we were already beginning to see differing views, which we felt would become increasingly confusing to clinicians. Not what we need during a very fast moving and I'd say anxiety-provoking pandemic. So with support from NHMRC and funding from a number of groups, we established the task force in mid-March. So the purpose of the task force is to provide a trusted, unified national clinical voice, providing guidance and reassurance to Australian clinicians during the pandemic. I think the value that we provide is really a combination of 3 major attributes. So first of all, that we have participation of now 29 peak national clinical groups. So we speak as one. That we use rigorous evidence-based processes. This is not about cutting corners. We use all the methods that have been developed for high quality evidence and guidelines over the last 30 years. And we keep it up to date with the latest research. And so we've moved now to, in this model, to update the guidelines every week. And the scope, important to note, is clinical care of people with suspected or confirmed COVID-19. So we don't cover general aspects of care for people in the era of COVID-19 nor infection control questions. That's the remit of ICARE, which is the national group responsible for infection control guidelines. So as I mentioned, now 29 groups involved and growing every week. So we've been extremely impressed with the buy-in and participation and support from all of these groups, and very much a sense of that we can work together and really create something that is of use to Australian clinicians. And then also just to mention, we have a number of other partners. So the task force is hosted by Cochrane Australia at Monash University within the School of Public Health and Preventive Medicine. Herico is a evidence synthesis company that has been working with us. Consumers Health Forum, importantly, is our major consumer partner, and we're working closely with them on consumer participation. NPS Medicine-Wise, as we've described previously, is a formal partner now of the task force, and we're very excited about that partnership. And then we use these technologies, Covidence and Magicap, also partner with the Commission on Safety and Quality in Healthcare. And just to note, our funders, Australian Government through MRFF, Victorian State Government, and philanthropy in Potter Foundation, Equity Trustees, and Lord Mayor's Charitable Foundation. As I mentioned, this is not about cutting corners. We use all the established quality methods for guideline development. So that is the GRADE set of methods. So all of the evidence synthesis, meta-analysis, evidence profiles that are used in that process. And then, as I mentioned, we're using an online platform called Magicap, which is a platform for the development and dissemination of guidelines, which we've been using over the last several years, which provides a very structured way of presenting the recommendations, and then also the ability of clinicians to actually dig deeper so they can look for the underlying evidence if that's what they're interested in understanding. In terms of the topics that we're covering, just to give you some sense, so recommendations that we have already issued around disease severity, monitoring and markers of clinical deterioration, antivirals and other disease modifying treatments, and of course that's quite topical, are many aspects of respiratory support, some aspects of care for people with comorbidities such as asthma and the use of steroids in that patient population, anticoagulants, ACE inhibitors and ARBs. And you can see there listed also some of the other topics of evidence that's under review. I'll also just highlight that in addition to the formal living guideline, which will be submitted to NHMRC for formal approval. And I should also note fantastic support from NHMRC, as approval of a living guideline requires quite substantial modifications to their sort of normal processes, but they've been very supportive and very engaged in this. So in addition to that formal living guideline, we have developed a number of clinical flowcharts that summarise suggested care for particular populations and groups with mild, moderate, severe or critical disease. And they combine our own living recommendations, practice points and recommendations from other groups. This is a very busy slide, but just to give you a brief overview of the process, as I mentioned, we are updating the guidelines every week. And so we have a weekly schedule by which our guidelines team are maintaining the living systematic reviews, and then feed through the evidence profiles and draft flowcharts through to currently 6 panels. So you can see primary and chronic care, hospital and acute care, critical care were our first 3 panels. And then more recently, we have established panels for special populations, so children, pregnant women, and palliative and aged care. They developed draft recommendations each week, which are then fed through to the guideline leadership group. So that is the peak clinical body of the task force, which includes clinical representatives from each of the member organisations, who then review and recommend approval to our steering committee. They're also composed of representatives from each of the member organisations. And so each week we go through this cycle. We will always wait until we get full consensus before publication. And then we publish each week through the website and through Magicap. Also, just to note a few other groups here. So importantly, the consumer panel. So in consultation with Consumers Health Forum, it was agreed that the most optimised model for consumer involvement would be to have a distinct consumer panel and then representatives from that panel on the guideline leadership group. We also have an expert advisory group, which is a group of subspecialist clinicians with expertise in particular areas, who are available as needed to join any of our existing panels to discuss specific topics. And importantly, we also have a very well credentialed International Conflicts of Interest Committee, which review the competing interests of any of the members of our panels or other groups and provide advice about their appropriate participation. So this is just a screenshot of our website where the recommendations are published, and the URL is there. And so, we are very conscious that we are disseminating the evidence through the website, and we have quite substantial communications activities to alert different clinical groups around the country to any updates that we promulgate each week. But we are not involved in the knowledge translation aspects of this work. It is certainly well beyond the scope of the task force itself. And so we're very interested in partnering with other groups who may be well positioned and interested in pursuing specific knowledge translation activities to assist the uptake of these recommendations. I think it's also important to note that one of the benefits of the living model is that we can be responsive to the needs of clinicians. So as opposed to a traditional guideline that might be produced every, say, 3 to 5 years, in this model, we can seek the concerns, issues, questions of clinicians, and then use that to shape the ongoing work of our panels. So this is a form that's on our website where we're encouraging clinicians to go and submit their questions. And we have a process by which we then collate, refine, prioritise, and use that to prioritise the work and topics examined by each of our panels. So we very much see this as a two-way communication between clinicians and the task force guideline panels. So just a very brief summary of where we're up to. So we launched at the start of April. That was 2 weeks after our initial establishment. We've been doing weekly updates since then. We have 29 organisations, as I said, 9 expert panels and groups, 35 recommendations so far, and 5 clinical flowcharts. And we're getting quite good engagement through the website in terms of the website sessions and flowchart downloads. There's obviously a lot of evidence that we're working through each day, and I imagine all of you are aware that that evidence is increasing week by week. So it's it is a substantial amount of work keeping the guidelines up to date, but we have a very experienced team who's working on this. And I should also note that this is novel. There really isn't guidelines that are evidence-based using grade methodology have really not been updated weekly anywhere before. And so this work is getting a reasonable amount of interest from other guideline groups around the world. So that's the end of my presentation. And we've got, I think, substantial amount of time now to take questions and have some discussion. So thank you for your time, but very interested in thoughts and questions.
Thanks for a fantastic presentation, Julian. I'll open the floor to everyone for questions or any feedback you may have as well.
Hi, Anne-Marie, and hi, Julian. My name's Margaret. I'm from RANSCO, Royal Australian New Zealand College of Ophthalmology. Julian, I was just interested in how you said that you needed like consensus before publishing, and I just wondered about that process, how you manage that.
No, great question. As you might imagine, that requires quite a lot of detailed management of the partnerships and the process each week. So I have to say again, all of our partner organisations have been extremely well engaged, and I think, as many of you would have experienced through this pandemic, there's generally a sense of a willingness to do things a bit differently than people have in the past. And so, we're very grateful for each of our member organisations for their ability to work with very rapid turnaround. their first indication of a recommendation coming forward may come from members of their organisation who are participating in a particular panel. But certainly on a Friday afternoon when we circulate the draft, that is going to the Guideline Leadership Group for their meeting the following Monday. After the Guideline Leadership Group meets on the Monday, we then have the recommendations go to the Steering Committee on Tuesday. The Steering Committee meets on Wednesday lunchtime, and then we ask for approval by Thursday lunchtime. So that final piece of approval, the member organisations have 24 hours. So I think you would know that that is dramatically shorter than would traditionally be the case. But they also have that kind of lead-in period where they have some awareness from the previous Friday, so about 6 days or so. But having said that, that's still a very short period of time. Now, what we've done is really encourage members to let us know early if they have any concerns. And of course, they have members sitting on their individual panels and the Guideline Leadership Group. And of course, concerns can be expressed through those mechanisms or directly. And in situations where we have some differing views, we of course work quite just very actively with groups to understand what the concerns are and to see whether we can make some modifications or tweaks in order to be able to obtain consensus. If we can't obtain consensus, in the living model, one of the advantages is we can pause that recommendation and not publish that week, and then revisit that over the following week. So we've found that so far has been workable, and we've not had situations that have kind of broken the model. Thanks
for the question, Margaret. We have a comment in the meeting chat. Julian, I'm not sure if you can see, so I'll read it out. From Mark Ziegenfuss. So, hi, the expert advisory panel is very haematology biased. Is this a good thing for an advisory panel? Perhaps more diversity, particularly on this panel, may be advisable. Excuse the pun.
Yeah, no, it's a great point. It's really just a reflection of what we've needed from the advisory group so far. And so the first instance of drawing on advisory panel or inviting people to join the advisory panel and then asking them to join one of the panel meetings was around the question of anticoagulation. And so we worked with TANS, the Thrombosis and Hemostasis Society of Australia and New Zealand, identified relevant people with expertise in that area and then invited them to the panel. But that expert advisory group will grow over time. So, for example, at the moment we are exploring a CPR protocol, and so that will be another opportunity to invite people to do that. It's one of the joys of working from home, isn't it? Is that my dog in the closet. There's some more questions in the chat. Do you want me to address them, Henry?
Yeah, if you can I can read them out for you.
That's fine. Yeah, so I've got Helen Belcher's asking, I'm interested in how the consumer panel provides input into the process. Yeah, so it's a great question. So the consumer panel is relatively new, based on the formation of the partnership with Consumers Health Forum, so still being worked out. But in the end, it is up to the consumers on that panel to really instruct us in how they want to work. But they will be reviewing the recommendations that are coming through from the panels, and then also providing other thoughts and advice and guidance to the task force. And as I mentioned, the chairs of that group also sit on the Guideline Leadership Group, which is the peak clinical body. From Andrew Campbell, I conducted evidence horizon scanning for medication-related treatment and management of COVID-19 at WA Department of Health. As time progressed, the quality of evidence really dropped off and became crowded with many opinion pieces that simply echoed previous work. What methods does the team use to maintain efficiency and effectiveness in this sort of research environment? Yeah, thanks very much, Andrew. And we've had discussions with your department and some great, I think, opportunities for us working more closely together. There's certainly a lot of opinion flowing around at the moment. We, of course, are not looking at opinion. We're looking at formal research outputs. We do look at preprints and peer-reviewed literature. With preprints, we of course do use that information with the caveat that it has not been peer-reviewed, and we also will track to identify when that study has had a formal peer-reviewed publication to ensure that we're aware of any changes that may have occurred during the publication process. So having said that, there is a lot of information, a lot of research being published around COVID-19. We use a number of technologies, including machine learning, crowdsourcing, different software platforms in order to make that job more efficient. And we also have very experienced information specialists. I should also mention that we have established a jurisdictional liaison group, which is a collaboration between ourselves, Commonwealth Government, and the jurisdictional governments as a method by which we can communicate easily and frequently regarding the work of the task force. So we provide early awareness to state, territory and Commonwealth Departments of Health regarding the recommendations when they're in draft form, in order to obtain any advice or guidance regarding implementation issues in those jurisdictions. And then each week we also provide a communique summarising the new recommendations of the task force. Okay, I'll move now to so Peter Turner. Radiology and nuclear medicine fit into your clinical group. So we have not yet included radiology or nuclear medicine. We're certainly very open to that. I think if you're have some role within those groups, then we'd be very keen to hear from you. So please either send myself or Rhiannon Tate an email. Rhiannon's on the call, or else there's an email contact on the website. So from Mark Zegenfuss, if we tout a live dynamic group, then perhaps this panel should be ad hoc and reflect strengths and expertise to new problems as they arise. I'm not quite following the question.
Sorry, that was in relation to the advisory panel. That as you have coagulopathies, you have hematologists, as you have, whatever other issues that maybe that panel can invite as is required.
Yeah, that's right. It's designed to be a flexible mechanism by which we can draw on expertise from around Australia on an as-needs basis, so that people can be onboarded, go through all the competing interest processes that we have, and then able to provide advice into one or more of the guideline panels.
So Julian, we have 39 champion health services as part of the Choose Wisely network nationally. I guess one of the questions is, what would you like to see, or how do you think health services can help support the task force?
I think we're very interested in the opposite question, which is how can we best help you? As I mentioned earlier, we are, of course, very aware that changing practice is not just about producing guidelines, even if they are up to date with the latest research. There are many complex challenges that stand between a guideline recommendation and practice change. And I think this network is very well placed to understand all of those challenges. And so in the context of these health services responding to the COVID-19 pandemic, I'd be very interested in thoughts about what more we could do to help you. And perhaps also if there are specific thoughts around models or partnerships or particular initiatives that might assist clinicians on the ground.
Thanks, Julian. And Rhiannon has put her email in the message thread, so if anybody wants to touch base, you can send her an email as well there, as well as on your website where Julian had the screenshot before. And there's just another question from Peter Turner there in the messages.
Yeah, no, Peter, thanks for that. Yeah, we are, of course, aware of the communities of practice, and we know ACI well, and we're working closely with John Friedrich and others in the critical incident unit to really synergize. So the CIU, I think, provides a very important function in terms of very rapidly responsive guidance to the New South Wales government. And both in New South Wales and through other similar clinical networks in other states, we're keen to strengthen the links between the task force, our member organisations and those networks to ensure that there's consistent voice, again, to clinicians, that we're not duplicating effort, and that we can also support those networks as best as possible. So again, if you have any particular suggestions, I'd encourage you to get in contact, and you could do that by emailing Rhiannon, whose email is in the chat. And I don't think Rhiannon was introduced, so just to mention that Rhiannon is Director for Strategy and Engagement for the Task Force. So very open to just hearing any immediate thoughts on what we might be able to do to better help your health services or any other ideas. But otherwise, of course, very happy to follow up by email later on.
Okay, we might wrap it up there then, Julian. Did you have anything else to add?
Just, I'm personally, and I think as a group, we're great fans of Choosing Wisely. So, again, we've talked about the work of the task force, but, if there's anything else we can do specifically to help the Choosing Wisely agenda, then please let us know.
Great. Thanks so much for a fantastic and informative presentation, and thanks Rhiannon as well for coming along. If anybody can't see the messages, I will circulate Rhiannon's email once I have the video link up and running, and you can circulate that to anyone within your health services as well, just to spread the word. And I think Simon Towle from WA has a comment there.
That's a great last question. Do you want me to respond, Anne-Marie?
Yes, please. Thank you.
I think there's a very clear link, I think, between platform trials and living evidence. So you can think of, from, the piece of the ecosystem in which we're producing new information and the piece of the ecosystem in which we're synthesizing that research information and developing guidelines as being persistent. And that, I think, is the key difference between, say, conventional trials or conventional guidelines. And essentially, they're very complementary. We've established infrastructure in which whenever an output from a platform trial is available, that can be very quickly incorporated into the guideline. That not only at clinical sites participating in those platform trials, but more broadly, that then can very rapidly become standard of care. And of course, then within the platform trial, other new interventions can be brought in. Yeah, and I think REMAC-CAP is a great example of that.
Okay, great. So we'll wrap it up there. Thanks again so much, and we look forward to working with you, Julian and Rhiannon as well.
That's great.
Thanks everyone. That was the biggest turnout for a meeting too. Thanks everyone. Bye.
Pleasure. Bye-bye.